Well, good afternoon, ladies and gentlemen. The official theme of our conference has been demonstrating the value of hospice care. But if there has been a subtext running through virtually every session that we've had, it is change. We were started off by that inspirational session with Helen Bevan, which was all about change. And the last session that I attended before lunch was about how 3 of our hospices are rising tremendously well to the challenges of the change which we're undergoing at present, and which presents us with such a formidable array of challenges. But if anyone thought that the pace of change is slowing, I'm afraid that they are gravely mistaken, because there are more changes afoot, and they will pose their own formidable challenges. And to guide us through some of the pitfalls that lie ahead, we are very, very lucky to have with us in this replacement session Jonathan Ellis, who is the Director of Policy and Advocacy at Hospice UK, and Dr. Fliss Murtagh on my left, Reader and Consultant in Palliative Medicine at the Cicely Saunders Institute, and they have both been volunteered to step in to guide us through the pitfalls of the funding review and the proposals that might emerge from it. So I'm going to ask Jonathan to start, Fliss then to speak afterwards, and then we'll open it up for questions from the floor. Jonathan, over to you.
Thank you very much, Michael. Yes, the funding review, it's kind of been the elephant in the room, hasn't it, over the last couple of days, and no doubt will bring about another period of significant change for us all to grapple with. What I'm going to try and cover in the next few minutes is a bit of a snapshot of where we are with the work on the funding review, where we're not, importantly, because actually understanding where we're not is almost more important than understanding where we are. Where next, in terms of the next steps, what's going to happen and when can we expect it to happen? And finally, what are the outstanding issues? What are some of the concerns that we as Hospice UK, and I know many of you individually, have been feeding back into the process of the development of the new funding system that we need to make sure get taken into account? Just as a show of hands, how many of you attended one of the NHS England engagement events that have been running over the last month? Actually, that's better than I expected. Keeping your hands up, how many of you, in light of attending those events, feel that you've got a reasonably good handle on currencies, tariffs, prices, where we are and where we're not? A few that fall, yes, and a few in the middle, and I think that's probably completely to be expected. So over the last month, NHS England has been consulting on an important step in the process of developing the new funding system, which has been the very first draft, a very initial draft of a development currency for palliative care. And what I just want to spend a couple of minutes now going through is just helping us understand collectively what that means and what it doesn't. Before I do that, it's worth just recapping on where this all came from. And this work has its origins actually pre-2010 in the conversations that we were having with all of the political parties about the challenge that the variation, the inconsistency in the way in which hospices are supported by the NHS actually presents operationally for the hospice movement, and the need for some sort of consistent national solution, or at least a solution that will try and tackle some of those variations. So we were delighted when the new government, when it came to power, committed to establishing a palliative care funding review to answer that question, but also the broader question about the variation in the resourcing and provision of palliative care generally. Some of you may remember that statistic that was identified a little further down the line about the difference in what primary care trusts at the time were spending per death. I think at one end of the extreme it was a PCT spending about £180 per death. At the other end of the extreme, there was a PCT that was spending over £4,000 per death. It's just symptomatic of a variation that we are all familiar with in terms of the support for hospice and palliative care. So the review was set up very quickly in 2010, chaired by Tom Hughes-Hallett from Marie Curie. And undertook a very intensive period of engagement and consultation with the hospice and palliative care community to help them understand what the solutions might actually look like. Their final report was published in the summer of 2011, and I think for me, the take-home message from that report was that there was a great paucity of data in relation to palliative care to really enable any clear decisions to be taken on how this new system might be developed. And I guess in many ways that's an answer we probably could have predicted from the very beginning. So to tackle that, the Department of Health established a number of what were called pilots, but actually slightly misleadingly called pilots. They were really, in essence, data collection sites to try and improve the data, to get a better handle on the needs that people have in relation to palliative care, how those needs are met, and what the costs of meeting those needs actually might be. And is there anyone in the room who was involved in one of those data collection pilots over the last couple of years? Couple of hands, few hands dotted around. So you'll be very familiar with the challenges that the pilots presented themselves. Those pilots ran for 2 years, collecting data on needs, on costs, on a number of different factors relating to palliative care, and completed their work earlier this year. With that data then in hand, it's enabled NHS England, obviously an organisation that back in 2010 didn't exist, but it enabled NHS England and the team at Public Health England, with support of colleagues from around the palliative care community and the academic community, to really interrogate that and start to develop a sense of what this new funding system might begin to look like. And that's really where we are right now. And so the concept of a currency, very counterintuitively, it's certainly something I struggled with at the beginning. Currency has nothing to do with money in this context. It's a very difficult thing to get our heads around, and particularly for us within the hospice movement who aren't used to the language of currency and tariff and all of them, these mechanisms that are very familiar and very widely used within the NHS. So a currency, as distinct from pricing or tariff or anything to do with money, is really just a consistent way of grouping healthcare into units. It's grouping the things that go together to be able to meet a person's need or to provide a particular service that are clinically similar and have similar resource costs. So it's just a way of grouping activities, inputs, outputs, needs, however you might want to cut it. And that's of course very different from the question then of how you pay for that, how you resource those needs. So the first draft of the currency which NHS England has been consulting on is really just asking the question of, does what they've proposed look as though it broadly makes sense, broadly resonates with a sort of common sense approach to how, and an evidence-based approach importantly, to how those needs could be grouped in a different way to enable the next phase of the work to begin. So, What we're not talking about, or rather what NHS England currently is not talking about, are questions of pricing and tariff. So how we ascribe cost and price potentially to that currency. We're also importantly not talking at this stage about the scope of what is in and out of this new funding system, and I'll come back to that in just a second because it's a really, really important point that we need to get some clarity on to be able to move forward. In terms of where next, Hospice UK submitted a response to this engagement, to the consultation, last Friday, and our response will be going out to all of you via Executive News Online and via the website, hopefully at the end of this week. And that response was very helpfully supported and significant input from members through the policy reading group and others who were very helpful in providing some guidance on that. From here, NHS England anticipates that there'll be a further draft, an updated draft currency, later in this calendar year, so later in December, with a final version of the currency available in February of next year. The idea being that during 2015-16 financial year, local health economies, so CCGs, hospices, acute sector partners, community providers and others, will be able to begin to actually test that currency in sort of real life, on the ground, as it were, to make sure that actually what's being proposed resonates with real experience and actually appears to be appropriate for further work. You may have picked up that from the engagement document and from some of the conversations that have been going on recently, that the currency at this stage is not intended to be mandated. And what that means is it's not a requirement for the NHS to use the currency to begin to think about how they plan and commission and provision palliative care services to meet those needs that exist within their community. The intention is, in reality, that the currency NHS England hopes will be mandated from 2017-18. So if you like, there's a period now which is more about true piloting than the period we've just come through over the last 2 years in terms of the data collection work. So the next financial year will be about testing and hopefully refining that currency. So hospice engagement in that, I think, is going to be very, very important. And I hope that many of you will have considered and be considering putting yourselves forward to engage in that work over the next 12 months. Now, the link with pricing and tariff from here is actually a question much further down the line. And the work on that, the development work on that, won't even really begin until the currency is out there and being tested, and NHS England are getting feedback from different locations, different sites, about how accurate, inaccurate, useful or unuseful that currency is. So the pricing and the tariff work will follow eventually. Well, I'll come back to that, but not at the moment in terms of the sequencing. And I say that it may follow because there is no decision has been taken on whether the currency that's being developed will necessarily lead to prices and tariffs in the sense of the sort of payment by results approach that we see widely used within the NHS. There's no cause and effect from currency to tariff, and there are a number of different scenarios that may well play out over the next couple of years. It is quite possible, for example, to have a national currency for services without a national tariff or without a national approach to pricing. And those questions will follow over the next 18 months or so as well. So I just wanted to highlight some of the issues that we included within our response, within our submission, and which you will see in more detail later this week. And there are really, I think, four principal issues. The first is the question I mentioned earlier about what's in and what's out, what's going to be included in this new funding system and what's going to be excluded, potentially, in this new funding system. Some of you may recall that in Tom Hughes-Hallett's original report, he made a number of recommendations about a definition of what he termed dedicated palliative care. And this was trying to find a way of defining more clearly and more articulately what is the NHS responsibility and what he described as society's responsibility, or in a sense, what is it that the NHS should be providing universally to everyone with a particular need, and where are we looking more at a partnership, the partnership that we've seen for many years in the hospice community between the NHS and the voluntary sector. It was a very imperfect model, but of course it led to some recommendations about what should be included in the tariff and in the currency and tariff work to follow, and what should be excluded. And some of the, I think one of the key concerns that we as a hospice movement reflected during the work on the funding review and have continued to echo is a deep anxiety that what had been recommended and proposed as being within the scope of this new funding system, which was essentially, it was issues like the coordination of care, the assessment of needs, clinical needs arising from those assessments, etc., and what was recommended as being outside of the scope of the new funding system, which included things like bereavement support, carer support, respite care for adults, and spiritual care. For us as a movement, which places equal weight on medical, clinical, spiritual, emotional, psychosocial needs, that feels a very uncomfortable position for us to potentially be in. So the work that NHS England has done so far doesn't answer those particular questions, those critical questions, because those, of course, are questions that need to be taken quite appropriately by the government of the day. These are big political decisions about the boundaries, the limits of the NHS responsibility. So our submission really highlighted the importance of NHS England continuing to press the Department of Health for some clarity on its intended approach moving forward. And I think one of my personal concerns is at the moment, given that we're working on the basis of recommendations in the report that the government hasn't yet responded to, for very understandable reason, but hasn't yet responded to, means that all of the work is proceeding on the basis of assumption rather than decision, and we need the decision, we need the clarity moving forward. Linked to that is the second key issue, which is this issue of the scope of the needs that will be included. So actually this is back to that question of what is dedicated palliative care, if that's a term that still has resonance and still has value. What are those boundaries? So the first issue is we need the clarity from government, and the second is what should the boundaries actually be? And I think one of the anxieties from the work over the last couple of months is that what appears to me to be a further narrowing and tightening of the scope of the work increasingly to clinical elements, medical elements, if you like, I think falling into the trap of the whole debate about specialist palliative care versus generalist palliative care. And there are some very real dangers with going down the path of a funding system which is linked purely to specialist palliative care needs, however politically realistic that may be as the ultimate position that whatever government of the day may need to get to. And there are a number of perverse incentives, a number of challenges that presents. So, for example, a very medically focused approach to meeting those needs runs the risk of actually creating a financial incentive around medical at the expense of the spiritual, the social, the psychosocial, the emotional needs that a person might have. As soon as you put money to something, that's what will almost inevitably be prioritised. It runs the risk of creating, I think, a two-tier system as well. So what happens to the people who don't pass that test as having specialist palliative care needs? Will their needs have the same sort of proportion of resource spent on meeting them and supporting them and their families? Or are we actually in danger of creating a cliff edge where people will fall over? And thirdly, that it fundamentally misunderstands the work that all of you do, the work that hospices do, that hospice care does not fit neatly into a specialist or a generalist box. There will be things that many, if not all of you do, which some things which could fall within a definition of specialist palliative care, however that might be defined, but also many things that would not fall within a definition of specialist palliative care. And how is this approach going to disaggregate and handle that complexity in terms of the very person-centred approach that hospice care takes to meeting a person's needs, whatever they might be? So a number of dangers around what's in, what's out, and how the boundaries are defined. The third point we raised is that it's impossible to separate out the issues of how needs are currently met and how resources are currently expended to meet those needs from the development of a new funding system. And one of the things that NHS England, I'm sure many of you who would have been at the engagement events would have picked up, they've been very keen to try and separate this question of funding from currency and treat it very much as almost a technical exercise on how we develop this currency. And one of our arguments has been, in our response, and you will see, is that actually you cannot do that. It's impossible to separate out the way in which needs and the resources that are spent currently in meeting people's needs from how this new funding system might develop in the future. And let me explain what I mean. So the data collection sites, those of you who are involved in the data collection work over the last couple of years will know this, that the data that you were collecting was for all of your activity. It was all of the services, all of the support, and all of the needs that you were meeting that NHS England had asked you to collect data on. So the work to extract from that data a potential model for moving forward, by its very definition, includes services and needs that are met entirely and at least partially through charitable resource. So it's not been a data collection exercise, which is purely about looking at what the NHS is currently spending on meeting those needs. It's important also to note that this is the very first time in relation to this kind of approach that the NHS takes to tariffs and currencies, etc. It's the very, very first time that the NHS has attempted to do that in a system, in a part of healthcare, where the voluntary sector is such a significant provider and funder of care. And I think one of the very reassuring things from those engagement events over the last few weeks has been the very clear recognition of the challenge that presents. But to me, that's another reason why it's impossible to separate out this question of the very important relationship between the charitable resource, that billion-pound sector that David talked about earlier, and the NHS contribution to that from the work moving forward. And finally, we highlight, there's lots of other things in our submission, but as a final sort of key area, which is actually around the next steps and perhaps some of the challenges for implementation moving forward. And the issue that came back loud and clear from hospices and that we've echoed in our submission is the challenge that we all face in relation to data collection and perhaps at a very more practical end, IT systems, patient information systems, to collect and use that data. Many of you will be very aware of the challenges of data collection and patient information systems and the variety of approaches that exist within the hospice movement, driven very largely by the huge variation that we have within the hospice community, from very large hospices who have the capacity and the capability to invest in these sophisticated patient information systems that will feed the system the data it needs, to the very small services who simply don't have the resource and the capacity to be able to invest in that sort of way. So a very significant challenge for the next, and a very urgent challenge that we have highlighted, is the need for the system, however that might operate, whether it's nationally or even locally down to CCGs, to make a very significant investment and support to the hospice community to help ensure that we are up to speed and prepared and have the capacity and the resource to be able to meet the challenge of the IT and data systems that we all need in the future. And it's very interesting that that's been a theme over the last couple of days as we've been thinking about how we make better use of data, what data we need in the future, and some practical questions about how that might work in operationally. The next challenge in relation to the next phase of the work really is recognizing the fact that we are in a very different world to that which we were in 2010. So in 2010, we still had the structures of a broadly top-down NHS system that was run from Whitehall. And today, of course, we have almost the exact polar opposite of a healthcare system which is much more locally based and locally driven without that same degree of central control. On top of those structural changes, of course, we've got some brand new initiatives and new approaches. Now, whether we think they're a good idea or not is almost irrelevant, but some new approaches, some new developments which have come on stream since the work and alongside the work on developing this new palliative care funding system. And I'll just pick out one example just to illustrate the point, which has come up a couple of times over the last 2 days, which is the Better Care Fund, which is about bringing health resource and local government resource in particular together in an integrated way to better meet people's needs. So does it make sense, one of the questions we pose, to continue down a path which has taken us actually, potentially at least, into an ever narrower description of specialist palliative care at precisely the time when the broader system is looking more expansively and more holistically at how investment can be made in meeting people's more holistic needs right across the spectrum. And so we need to factor some of those very significant policy changes into the system as it moves forward too. Finally, we reminded them, and I'm not sure how many of you may have been around or involved at the time, but way back in 2010 when the funding review work started, Hospice UK, obviously then as Help the Hospices, undertook a very significant engagement and dialogue with member hospices about what you expected the funding system to deliver. And if you recall, we came up with a series of what we call 9 key tests, 9 things that we thought, however the funding system develops over the next few years, that we would test it against. We would ensure that it wanted, that it delivered on these 9 key tests. And we've reminded them, NHS England, of those 9 key tests in our submission too. And I just briefly wanted to remind you what those were. We'll be doing some more work over the next few months to update and review these 9 tests to make sure that they're still resonant. But I think broadly, the concept, at a conceptual level, it still works. So the first test was about supporting localism, and this was about recognizing the variation, the highly localized nature of hospice care, and not wanting a funding system that did something to undermine that and that removed that very important connection that hospices have with local communities as being an essential part of how hospice care is delivered. So supporting localism was number one. Number two was being needs-based, not resource-based. So we wanted to ensure that the funding system, that the work on developing the funding system started from and remained singularly focused on better ways and most effective ways of meeting the needs that people have, rather than being an exercise which is trying to carve the cake in a slightly different way. So we were saying it shouldn't start from the available resource that we have currently. It should start from the needs that people with palliative care needs actually have and how those can best be met. Thirdly was a test around consistency. So we wanted to make sure that the way in which funding ultimately is allocated should be consistent as an approach, both geographically and over time. So we wanted to make sure that the funding system answered the challenge that it was set up to answer, which was to tackle the variation in the approaches that are taken locally. The fourth test was around the need for the system to be cost reflective. So it needs to take into account the costs of meeting needs and also the variations in the costs of meeting needs from location to location. So the challenge of providing, for example, just plucking an example out of the air, a hospice at home service in a relatively defined metropolitan area will be very different to the cost of providing a hospice at home service in a very isolated rural community, for example. The fifth test was around transparency, and this was really, again, trying to answer this, tackle the complexity that we see in the current arrangements and continuing arrangements. So we need a transparent system, a mechanism for distributing funding and for meeting needs, which is based on a consistent, transparent framework. It needs to be sustainable. That was the sixth test. And this was about providing long-term confidence, long-term stability to the hospice sector in particular, but actually to the palliative care community more widely, to enable that investment to be made and new services to be delivered or expanded or developed in different ways. The seventh, perhaps, is probably the most challenging, is the test of how straightforward this system might be. And this was really just warning about the dangers of an overly bureaucratic, complex funding solution that actually could result in higher administration costs to not only to hospices but to other providers, and potentially wiping out any economic benefit of a fairer and more consistent approach. The eighth was a question of fairness and equity, a test of fairness and equity. And this was about the need to ensure a level playing field for hospices as compared to other services, other providers of services. If you like, it was trying to identify the challenge of what amounts to the very significant voluntary sector subsidy that is currently underway within our hospice and palliative care community for what would otherwise be considered perhaps core NHS services, for example. And finally, and these are in no particular order, so please don't take any meaning from the sequence, the importance, the test around the need for this funding mechanism, however it emerges, to promote quality and to encourage innovation. There's no point us having a funding system which incentivizes the status quo or incentivizes average quality or heaven forbid even poor quality. So we need a mechanism which stretches, which puts patient need and quality at the forefront, and which really encourages the investment and encourages the innovation which has characterized the hospice community for a great number of years. So that's all I want to say. I'm conscious I talked a little longer than I anticipated, but hopefully that's given you a feel of some of the issues that we have been reflecting back to NHS England on your behalf and with your support. And very happy, obviously, a little later in this session to take any questions or comments that you may have.
Thank you very much. Thank you very much, Jonathan. And now Dr. Fliss Murtagh will give us her perspective on these impending changes.
Thank you. So it's a pleasure to be talking with you again. I hope it's not too much, twice in one day. But I really wanted to present a slightly contrasting view. So I'm going to be a bit of a rebel and take some advice from Helen Bevan of yesterday and actually look at things slightly differently. If we think back to when Cicely Saunders took palliative care, the emerging palliative care, out of the NHS and developed the idea and the reality of hospice outside of the NHS, I think what we're seeing now are some of the convulsions that are going on because of the need to import it back into the NHS. If anything, we've learnt from the LCP, the need to get it right in the wider NHS, wherever that may be. And I think there's some of the things we're seeing, the upheavals we're seeing, are around that struggle to bring some of the learning and the wisdom and the good quality care back into a wider NHS context. But I would be very positive about the developments of the development currency. I agree with Jonathan completely, it's the wrong term for it, but it's the NHS speak, I'm afraid. It isn't about money at all, as Jonathan has said, it's about people. It's a way of grouping people by their level of the complexity of their needs. And so, in a sense, we have achieved something quite major, because most of the patient-level funding approaches, the currencies that are in acute care, are based on diagnosis and procedures, and sometimes age and one or two other components. But then it's quite a shift for the NHS to take on different things to count, and that's what they mean by currency. What do you count that tells you that people are more or less complex in their needs and the resources that should follow them to deliver to their care? So we've actually persuaded the NHS, even though this is a very draft currency, to use two things. Phase of illness, what stage of illness is somebody in? You know, what's the actual things that are going on in their care at that point in time? And functional status. Now that is a leap forward. So I'm quite positive about it. I think there's room to be creative about how we take that forward. We too, from the Cicely Saunders Institute, delivered a response to the consultation. And one of the things we were keen to say to the team was, yes, it's good to have two criteria which are not about diagnosis and are not about procedures. Actually, that's quite a revolution. So we should be positive about being able to achieve that. Now, phase of illness, the evidence for that being a driver of cost is becoming wider. There was a paper published recently looking at whether phase of illness could reliably be used across professional groups, and it can. And also there's very good evidence from Australia that it does reflect the resources needed to deliver care. So if you're in an unstable phase, you need more resources. If you're stable, you need less resources. And that is really important to understand how that's playing out. So we have achieved something in the sector to get those two criteria in. What we haven't achieved is to get problem severity in its broadest meaning, not just physical symptoms, but across the spectrum. And one of the reasons I think that's the case is because that wasn't properly measured in the funding pilots. It is in one of the classes for children and young people, just in one category. But I think it needs to be more broadly incorporated into the funding review, because that, we know that the nature and severity of people's problems as they present to palliative care, whether it's generalist or specialist, those are the things that drive higher need for resource. So just to come back to the idea of the funding review, I think it's a step forward, because we were going to move anyway towards a per patient payment, and the alternative is to have a payment per head. So where I work at the moment, we have a locally agreed tariff, and it's based on the number of people we see, completely regardless of how long we see them for. And that's just not helpful, really, because we can see someone 2 or 3 times and we attract the same income as somebody who we see for 4 or 5 months, several times a week. So it's not quite right. That's where some of the inequity is, and this is taking us forward. So I think it should be congratulated, although I think we also have to have the open-eyed understanding of what is and isn't going on. So the next thing I want to implore you to do, because for me the subtext of this conference has been about collaboration and community and connection. I would implore you to go back to your communities, to the patients and the public that you work with, and help them understand that now is the time to lobby to say they want funding for all of their palliative care needs to be met by the NHS. That is what we need, because at the moment the patient and public voice is it's beginning to be heard very powerfully. And actually that's where we need to exert the pressure to really help change this as it evolves. So please go back and think, how can you engage your communities, the people who fundraise for your hospice, to think about whether we can challenge the NHS to include funding for all palliative care needs as part of NHS care. That has disadvantages because we have less control, but it has advantages because I think we need to move into a situation where it is perceived as part of NHS care. So, something to think about there. Now, I'm also going to talk further on what Jonathan raised, which is the question of what is in and what is out. And I think to make the case for this, we have to step outside of the world of palliative care. We have to step into the wider health, social, and other economy areas. So I'm going to just give you some tools, if you like, to take with you, to take away with you, to make the case for that. And I think we need 2 kind of categories of things. You remember, if those of you who came this morning to what I was presenting the House of Care with the 2 pillars of people's experience of healthcare, but also the outcomes that can be achieved for them. And that's how we have to approach people when we're trying to connect with them, change and influence them. We have to have a pocket full of evidence and a pocket full of experience. So the evidence is actually systematic knowledge about what is true, what's the case about palliative care. That's all that research is. It is systematic knowledge, not anecdotal knowledge, not, I think we're doing a good job, but systematic, deliberate knowledge which tells us this is the case. And in the other pocket, we need experience, which is people's stories of care. And we need to be able to pull something out of those pockets when we're connecting and influencing with our communities. So this, for me, is a snapshot of what you need to put in your evidence pocket. And I'm talking about evidence not for people in palliative care, but for people outside of palliative care in the wider health and social environment, in the wider economic context. So you need to be very clear about what palliative care does, and I think we should be starting to move away from specialist and talking about palliative care. We don't talk about specialist cardiology, we don't talk about specialist nephrology. Those specialties are confident in what they do, and I think we should be moving up to that level. So palliative care, what do we do in a palliative care team? It's core daily work, it's multidisciplinary teams, it's specialist skills and expertise, so additional training and expertise. It's both patients and families, and it's both direct and indirect care, where direct care is delivered to people themselves, and indirect care is supporting other professionals to deliver direct care. And we need to ask ourselves 4 questions. When we're talking to other people, this is what they will want to know. Does palliative care work? Is it cost effective? What can it offer the wider healthcare system? And then there's a 4th question, which I'm not going to dwell on because we've dwelt on it this morning, but what do we need to measure in palliative care to demonstrate the difference? So I can send in the references for this, but these are mostly systematic reviews. But if you look here at the evidence, we don't have the evidence in our individual services yet. We may have if outcomes are used more widely, but we can go to the research evidence and find out what we know about what works. And it's very clear if you look at the evidence. We know that palliative care gives better symptom control, improved communication, better emotional well-being and less depression, and those two are for both patients and their families. More satisfaction with care, and that's both with patients and families, and higher quality of life for both patients and their families. We know that. We have robust evidence to show it. Maybe not in St Elsewhere's, but from studies around the UK and internationally. So we can pull that out of our pocket, those 5 things, whenever we're talking to someone we need to influence. There is also a question to think about, a 6th item, which is about, does palliative care, especially delivered early, improve survival? And some of you may recognise the Temel study published in the New England Journal of Medicine from 2010, which was based in the US, and it's uncertain what we can translate into the UK context. But when they delivered early palliative care to people with metastatic lung cancer, they were suddenly surprised. They thought they would get better quality of life, better symptom control, but they were surprised to see a longer survival. Now, if you had a drug and you were putting it before NICE, this would win hands down. But because it's palliative care, it hasn't won hands down. A 2 to 3 month improvement in survival, well, that's great for a cancer drug, but somehow we haven't managed to make the case to the wider health economy of why early palliative care might be helpful. We need to repeat this in the UK, and a study is going on to that effect at the moment. Why did people live long? It was because they made earlier choices not to have toxic chemotherapy, which was killing them. They weren't spending so much time with complications and getting sick and dying earlier. That's a really important message, because that may be quite a profound message in cost-constrained health services where there's a lot of technology in care, and it's not always in keeping with what people want, as we've heard several times through this conference. So that's my first point. Is palliative care effective? Yes, in those 5 areas, and possibly early palliative care may have something to offer in relation to survival, but we need to test it in the UK and in other disease groups. The next point is palliative care cost effective? Well, there's been a recent comprehensive systematic review of the evidence from a group in Dublin, Charles Norman's group, which shows that although there is not a vast amount of evidence, some of it comes from the US, and it's uncertain how much we can translate, but almost every single study shows that those receiving palliative care cost less in terms of their overall health care. And if you've got about a 20% deficit in your health budget coming down the road, that's very attractive news. It's good quality care and potentially at a lower cost. However, a caution, this only relates to direct costs, and it doesn't consider informal care costs, the costs that fall onto the family. So we don't know enough about the costs that might be picked up by families in that situation. Most of the cost savings in this situation relate to reduction in the use of acute hospital-based care. So what's the context for this? Because I think we really have to think hard about this. People worry about actually, if care is shifted out of hospital, what about the community care cost? What about family burden of care, etc.? And that's a very, very realistic thing to shout about and ask the questions about. We know 25% of NHS spend is for people in the last year of life. It's very heavily weighted towards last year of life. Hospital costs are by far the largest cost elements of end-of-life care, and this is from work done by Martin Bardsley at the Nuffield. You'll have seen the report that came out recently looking at the last year of life and then the last 3 months of life. And they looked at both health and social care costs insofar as they could unpick the social care costs. They also tried to include inpatient hospice costs, but surprise, surprise, it was very hard to get any hospice costs, a difficulty. I was talking in the break to one of the few accountants who's attended this conference, and it was fascinating to have that discussion about, where are costs? What are we hearing about costs in this conference? It is very difficult to get costs of palliative care. We tried hard in the commissioned work for the funding review, and it was really very difficult. We did manage to get some cost data, but it was all owned by specific organisations, and it couldn't be put into the public domain. Difficult and challenging, and we're doing a detailed cost and resource use study at the moment to try and fill some of that gap. Anyway, the evidence from Martin Bardsley's work shows that the costs split up roughly like this: £4,500 for hospital costs, mostly unplanned emergency admissions, about £250 for district nurse costs, about £150 for GP visits, about £1,000 for local authority funded social care costs. They didn't have data on private care costs or voluntary sector care costs. They estimated approximately £500 for hospice inpatient costs. That's the average costs for people who died. If you look at it as a pie chart, that's what it looks like. The message here is, even if we doubled hospice costs or we doubled community costs, look at how it stacks up compared to the hospital mainly unplanned admission costs. That's why the CCGs are so interested in unplanned admission avoidance. So there's also some interesting work that was published in the BMJ earlier this year, around about June, July time, work from Canada where they looked at 11 community-based palliative care teams, and they looked at whether they could reduce emergency department visits and hospital admissions just in the last 2 weeks of life. And they were able to demonstrate across the teams, regardless of the actual configuration of care, as long as it was multidisciplinary with some specialist expertise providing both direct and indirect care, they were able to show about a third reduction just for the last 2 weeks of life. So if they had perhaps looked over a longer time period, we might have been able to see a much more substantive advantage. And I think this really challenges us to think hard about where's the money going in the total system, not just in the hospice and palliative care part. If we think hard about the population, we should be seeing most of the most complex people and then be supporting perhaps with indirect care some of the more intermediate level needs, and perhaps leaving the less complex to the primary and usual care teams. And I accept that over time people move up and down this triangle, and there's some uncertainty about how that's going to pan out. But if you allow for that sort of flexibility in the system, do we see the people with the most complex needs? I don't think we do. If you look at who is seen in hospice care, they are in that triangle and they cut across the boundaries. So if you have a non-cancer condition, you will be less likely to be in that box. If you have minority ethnic background, you'll be less likely to be in that box. If you are from a lower socioeconomic area, you'll be less likely to be in that box. Those are not the reasons we want to see there. We want to see complexity driving this, and most of the people we see in the higher end of the triangle. So that's why I think when we measure some of the outcomes I talked about this morning, we can assess both the complexity of people's needs and the kind of outcomes we can achieve in relation to those outcomes. I'm not going to talk more about that because I talked about it this morning. And we're doing a 5-year program at the moment, a research program called Sea Change, which is trying to build the evidence on the costs of this and how different models of care turn out in terms of their cost effectiveness. So in conclusion, remembering those 4 questions, does palliative care work? We've got to take something out of that evidence pocket to convince the people who are outside of the palliative world. Yes, it clearly works. Is it cost effective? Almost certainly, and it is likely to reduce the overall healthcare costs because of its effect on emergency admissions and unplanned admissions. And then we also need to think about demonstrating the outcomes we achieve to really convince people that the difference palliative care makes. Thank you.
Thank you very much indeed, Fliss. Well, both our speakers have given us immense food for thought. Who wants to ask the first question?
Peter Holliday, St Giles Hospice. Jonathan talked about looking for a consistent national solution. We heard you say that the currency will not be mandated immediately. The hope that it'll be mandated in about 3 years' time. But tariffs may still vary at a local level. You then listed the steps we had given to the NHS earlier, and they included localism and consistency. Aren't they mutually exclusive?
Shall I pick that up?
Yes,
No?
do.
Yes, it's part of the tension that exists, I think, in terms of what we want to achieve. I think it's possible, I believe, entirely, to have a consistent approach with local nuance, local subtlety. And the example I gave, particularly of providing a hospice at home service, is a very good example of the cost variance that there will be in providing a particular service. But, for example, we could well move towards, and I hope we would move towards, a nationally consistent approach to, for example, what needs should be met in relation to community-based needs in terms of hospice at home, and the approach that the NHS, to pick up Fliss's point about whether we want the NHS to be funding and providing all of this care, that's another issue for us to debate another day perhaps, but some consistent approach to what the NHS sees as its responsibility and the approach that it will take to best resourcing those needs. So there is a tension, but I think operationally it's possible to have a national approach with local variants in terms of tariffs and pricing particularly, which is exactly what we see, for example, in many of the tariffs and prices used within the NHS. So presently they have an element which is called another bit of tariff jargon called the market forces factor. So even where you have a national tariff and nationally defined prices, there is still scope for variance to respond to the very different levels of need, the very different challenges that, for example, a rural community might face as against a metropolitan community. So there's a tension, but they're not in conflict, I think would probably be my best summary of that.
Hello, Barbara Gale, Chief Exec, St Nicholas Hospice Care. Jonathan, as you know, locally we have spent probably nearly 2 years now constructing a very robust grant agreement that we're about to sign for 4 years with further extensions. And at the NHS funding workshop, I was assured that because grant agreements are part of the Health and Social Care Act, that they will still be a valid way of funding charities, which I personally feel is the best way forward. I worry about, Fliss, your comment about we should be lobbying for the NHS to pay for everything. Actually, whilst I wouldn't mind a bit more money, I am really concerned about the strings that are attached to more money, which means we will lose our independence and our ability to do that risk-taking and work flexibly, which our communities so needs. I am interested in doing the currency, oddly enough, because I think commissioners may use that, whatever funding arrangements we have, to see what we are actually doing. But I would like to see them develop to be more robust.
Yeah, I think I agree with you. I was being a bit challenging. But I do think there is something about palliative care being... I mean, there's been quite a bit in the World Health Organization and in Europe about palliative care by right, you know, it being part of a health system. And I think there's something very important about getting the NHS to think in terms of needing to deliver at least a substantive proportion of that, because at the moment it's all a bit hit and miss. The historical funding has just meant that some places do get more and some get less, and it's all it's not really something that's considered as part of what should be NHS. So I think there's something about shifting the way of thinking. But I agree with you, we wouldn't really want to see it all, because, you know, we would get less control, and we can't have that control over a really good system. Yeah.
Jonathan.
And quite apart from the fact that, of course, even just to stand still, the NHS would have to find an extra £1 billion just to resource what's currently being provided. But I just wanted to pick up your point, Barbara, about grant agreements and arrangements, because it's one of the things that in another stream of work that we've been pushing very hard for with NHS England around the contracting and commissioning mechanisms that are in place, and the reinforced message to commissioners that grant agreements are often an appropriate approach for commissioners to take where the NHS is not fully funding and properly commissioning the services that a charity might be providing. And just to let you know that NHS England is also has already embarked on a piece of work to strengthen that message to commissioners through the production of a template grant agreement for commissioners, to actually give them a tool that they can take off the shelf and begin to explore with charities like hospices. So I think grants are, certainly for the foreseeable future, are here to stay as an important tool in the toolbox that commissioners have at their disposal.
Thank you. Any more questions?
Michael Kerrin, St Joseph's Hospice in Hackney. I suppose one of my concerns about the obsession with NHS funding is that we're missing potential tricks about tracking and indeed trapping social care funding. And I just wondered if you had any observations on that. I mean, obviously, the Better Care Fund mechanism provides an approach, but not necessarily the resources. And I suppose, secondly, I was at the session this morning about the development of personal budgets. And is there anything to be said about how personal budgets also fit into what's going on?
I think that picks up precisely one of the fact that the world has changed since the review report was published. If you remember, with the funding pilot, and in no small part due to the pressure brought to bear by Hospice UK and other national organisations, persuaded the government to actually factor in social care and the ambition of providing non-means tested social care, so rolling in social care costs into end-of-life care and providing that hopefully potentially on a universal comprehensive basis further down the line. I think I would share your anxiety, Michael. I think I'm deeply concerned that the progress on that has been painfully slow, that the work on the currency and the subsequent work on the work to come on tariff will proceed, or pricing and tariff will proceed without robust data to help inform and intelligence to inform that combination of health and social care needs going forward. I know also that had the Minister been with us this afternoon, it's a concern that he shares very passionately about the importance of incorporating those elements. But you're right, things like the Better Care Fund, things like personal health budgets are taking us to a future in which health and care needs are almost are not considered in their traditional terms of being either universal healthcare needs or means-tested social care. We're just interested increasingly in needs. And certainly the approach to personal budgets is about giving people more flexibility to meet their needs in whatever creative ways they consider to be the most appropriate for them. So I think I would say I share your anxiety, and I think we need to speak as a movement with a very loud voice that a focus which is that is singularly focused on the clinical needs because of the largely, I hate to say, for the convenience of the fact that that's where we have the data and the intelligence, is the wrong approach for us to take.
One of the things I'd like to comment on is I started working with the funding review team when they originally, Tom Hughes-Hallett was leading it to do the review, and then I've been working with the team since on the pilots. And I worry because so many of the people have changed that there isn't a collective memory of what was originally decided at the beginning. So I think it's great that Hospice UK are reminding everyone of what was discussed and agreed at the beginning. One of the things I think that's really important to remember, there was discussion that there should be, if any development currency starts to become mandated, there should be a 5-year transition period to allow for hospices to adapt to the different financial flows in a steady way rather than overnight. And I think we should keep reminding them of that because it gets lost. So much gets lost as, you know, there was so much change in April 2013, and still I think people are trying to find the right place for how it's all panning out. So there's a real importance of being a collective memory and reminding people of what was originally said. So it's great.
First of all, let me thank both Jonathan and Fliss for stepping into the breach so magnificently and giving us such insights into what is inevitably a very complex and indeed rather murky picture of the future we are likely to face. And I'm sure you would all want to express your appreciation of them. Thank you both very much. Now, we've reached the time virtually when the conference was due to finish anyway, so I am going to formally close it, but if anyone wants to stay on afterwards, there's a kind of epilogue. I'm not sure that's quite the right word, because Roz is going to introduce the film of David's conversation with Atul Gawande, so if anybody wants to wait and watch that, they can do so. But I hope you will all agree that we've had a vibrant, challenging conference. I want to thank you all for attending. I want to thank you all for your contributions. Above all, I want to thank you for the extraordinary work which I know you are doing in your hospices and in your communities, and which I know you will continue to do over the next period before we meet again. So thank you very much indeed for everything that you're doing. I look forward to seeing you in Liverpool next year, if not before. I declare the conference closed.